Are you ready to comply with information blocking? Everybody's saying yes, right? So what I'm going to do is just a quick overview focused on the provider issues around information blocking, not the issues specific to health IT developers or HIEs or HINs, although you might find out that you could fit into multiple actor categories. I'm going to review some things that we're recommending that folks should be doing now, a few activities that you can wait on. There's a list of resources from ONC at the end of the slide deck. And then, of course, we'll have the questions. So diving right in, as many of you probably know, there are definitions of actors, and the actors are who the rule is applicable to. And so there's 4 definitions of actors. The first one is health IT developers of certified health IT. And for many on the call, I suspect you might think, well, I'm not a developer of certified health IT, so I don't really need to worry about this type of actor. But the one thing I will point out is that the definition says that it's not only those entities that develop it, but any entity that offers it. So the example I frequently use are organizations that have Epic. You may be engaged in Community Connect, which is the program in Epic where you're allowed to extend your instance of Epic to other parties like community physicians or smaller hospitals in your area. And if you are doing that, you are offering certified health IT, and thus you fit the definition of a certified health IT developer. And so just be cognizant, it's not just those tech companies that are actually developing the certified health IT. Now, if you develop a certified health IT within your own entity and it's for your own use, that does not make you a developer of certified health IT for purposes of information blocking. Now, providers, I didn't list out everyone who falls under this, but it's just about anybody who provides clinical care services in healthcare. So, most of you on the call are likely fitting the definition of a provider under the CMS regulations. There are also 2 other types of actors, HIEs or HINs. And they're listed here together because the definition is exactly the same. Now, to think through whether you're involved with or part of or run an HIE or HIN, it's, like many things, you have to really parse out the definition. Are you an individual or entity that determines, controls, or has the discretion to administer any requirement, policy, or agreement that permits, enables, or requires the use of any technology or service for access, exchange, or use of electronic health information among more than 2 unaffiliated individuals or entities that are enabled to exchange with each other, and it's for treatment, payment, and healthcare operation purposes. So if you're considering, thinking through, am I an HIE or HIN, you really need to parse out that definition and walk through it at each stage to see a yay or nay. Some other, the key definition of information blocking, it's a practice that, except as required by law or covered by an exception under the rule, is likely to interfere with access, exchange, or use of electronic health information. And the rule has a definition of electronic health information, which is equivalent to the designated record set under Hipaa. But the reason they created the EHI definition is because some of the actors, as you might discern, are not covered entities. So if they use the definition of PHI, that's applicable to covered entities, but some of the actors that information blocking is applicable to would not be covered entities. So they're using the definition of EHI. Some of the key dates, as we all know, April 5th for both compliance and enforcement of information blocking. And there's a distinction between what has to happen on April 5th and what has to happen October 6th of next year. On April 5th, you have to be ready to allow access, use, or exchange of the data elements that are listed under the USCDI. And, in the discussion after the presentation, I think we'll talk a bit more about what that means, because there have been several questions to ONC about what that means, because the definitions are not, the data elements in USCDI, people want a little more clarity on what would be included in that. Now, after October 6th of next year, you need to be prepared to allow access, use, or exchange of any data in the designated record set, or that would be equivalent to the designated record set. And I think that's going to be important to think through as you consider April 5th, sort of recognizing, is this something we have to be ready for? And so I'm working with a client now that they're looking at they have an application where they store scanned documents and images. And so they're parsing out the fact that for the scanned documents, they may need to be ready to share those April 5th. But for the scanned images, those images are not part of USCDI, so they don't have to be ready to share those until October 6th of next year. So I would encourage you, as you're thinking through this, to maybe look at what do we have to worry about for April 5th and apply resourcing to that. And you might be able to put a slight pause on what you have to be ready for by October 6th of next year. The enforcement penalties, the information blocking rule enforcement date is April 5th. However, I don't know, who knows what's going to happen with enforcement at this point. The OIG had indicated that they won't begin any enforcement actions until the final rule for civil monetary penalties is passed, or actually 60 days after that rule is passed. But the OIG is going to enforce against the certified health IT developers, HIEs, and HINs. And so when you look at that rule is going to be applicable to those actors. There is a proposed rule. And so once that proposed rule becomes finalized and 60 days later, that's when OIG will start looking at potential violations of information blocking. Now for providers, it's slightly different. The enforcement for providers is going to be some form of disincentives. There has not been a proposed rule published yet on what those disincentives will be. So we don't yet know what type of enforcement is going to occur. And since we don't have even a proposed rule, we know we're probably looking at 6 months from the date the proposed rule comes out, something in that ballpark when you think about the required notice and comment period, a time to review comments, and then publishing the rule. It theoretically could be a little shorter than that, but I think you're likely looking at 6 months from the date it's published at a minimum till the rule becomes final. What I haven't seen, and if anyone else on the call has, when we get into the Q&A, please chime in. I haven't seen anything that specifically says they won't enforce or they won't bring enforcement actions for information blocking practices that occurred after April 5th of this year, even though the enforcement rule might not be finalized. So whether they will, go retroactive for activity that was information blocking, I want to say probably not, but I haven't seen anything explicitly like we've seen from OIG where they've said we're not going to begin any enforcement action for information blocking practices until 60 days after the final rule has been published. The intent requirement under the rule is slightly different for the different groups of actors. For developers, HIEs, and HINs, they can be guilty if they know or should know that their practice is likely to interfere with, prevent, or materially discourage access, exchange, or use of EHI. For providers, it's a slightly higher intent standard that has to be proved. They have to know their practice is unreasonable and is likely to interfere with, prevent, or materially discourage access, exchange, or use of EHI. So it's a higher burden of proof for the enforcement bodies to bring an information blocking action against providers. And we'll talk maybe about this when we get into the Q&A about why that unreasonable piece might be important as you think through what your practices are and how you want to proceed after April 5th. Now, there are 8 exceptions to the rule. There are 5 exceptions that really address that you don't have to allow access, use, or exchange if you meet the exception. And then there are 3 exceptions that are really more around the way in which you share the information, whether you can charge fees for sharing the information or whether you can require some sort of licensing. I did put the website here, and I forgot to go back and double check it on one of my earlier presentations. Somebody tried to use the link and said it was not the correct link, and I realized it had a slight error, but I think this is in fact the correct link. And I've actually recopied this link on the last slide of this deck for where the exceptions can be found, because ONC did put together a PDF that kind of talks through the exceptions. But I would also encourage you to read the exceptions in the rule, because some of them are incredibly nuanced, and you're going to need to be careful if you're saying that your practice fits in the exception. And as with everything I'll talk about in a moment, document, document, document. So what activities do you need to be engaged in now? Well, here's some of the categories: determining what kind of actor you are, reviewing policies and procedures, reviewing contracts, assessing your system capabilities, and then training and education. So what type of actor is your organization? Well, I suspect most, if not all of you on the call are a healthcare provider, and so you're working with healthcare providers. But you could, as I pointed out, be a developer of certified health IT if you offer that health IT to another party. And again, just thinking through that and understanding that's going to be very important. You also might be a health information exchange or health information network. I'm working with a client now that is a provider and a developer. They thought they were an HIE or HIN. I'm not. I think there's one topic we're teasing out now to determine if it fits in those categories, and I don't think it will. But they originally, starting out in their project, actually thought they were all three types of actors, and that could very well be true. So again, don't just assume you're one type of actor. Make sure you've analyzed that. Reviewing your current policies and procedures. How do you currently allow patients access to their records? And what, if anything, might need to change about that in preparing for information blocking? And then the other thing that I still, when talking to a number of people, they're looking at this and saying, we're good. I had a communication with one entity and they said, well, we've just set it up so that everything's going to get released to the patient portal. And I said, well, that's okay for patients who use your portal. And that's also, but what about, do all your patients use your portal? If not, how are those other patients going to be allowed to access, use, or exchange? Have you thought through whether you're going to let them use apps to get to their data? And then also thinking about, it's not just patients. There are other third parties that can make requests to you for information. And if they make that request, if there's not a legal prohibition to sharing the information, and if it doesn't fit one of the exceptions, as a general premise, you're going to have to allow them to get the data. So, in theory, you may have competitors coming to you for information. And again, if you aren't legally prohibited from sharing it, or if you're not, if it doesn't fit the exception, you're going to have to give them the data. And thinking through practices like, I spent most of my career in-house in academic medical centers, so we always conducted research. And I was working with a client towards the end of last year, and one of their practices was that if a researcher came to them with a waiver of authorization to get data, they still communicated with the researcher and tried to strongly encourage them to assess whether they could use a de-identified data set, or whether they could use a limited data set. And if the researcher agreed, then they would share those types of data sets with them instead of all the data the researcher might have originally requested. And I said, I think you're going to have to reassess that and just make sure you're not going to trigger information blocking for that. Another practice that is not uncommon is if a researcher who's not otherwise associated with your organization comes and asks you for records, then that researcher, you might have a practice that says, well, we're happy to do this, but you're going to have to go to our IRB and get their approval before we will allow you to get the data. Well, if you can't find a legal requirement that they do that, then you're no longer going to be able to require that they do that. So this is the kind of thing that you need to think through. What are you going to share with other providers? And again, in the past, you might have just said to a competitor, no, we're not giving you the information. but under information blocking, that could be problematic. Public health entities may be asking you for more information. Health plans may be asking you for more information. And I put researchers, and there may be others. So it's not intended to be an exhaustive list. The point is, it's not just allowing access, use, or exchange for the patient. It's other parties as well. And again, what's your process for addressing exceptions to the rule? Who in your organization is going to have the authority to assert that the exception actually applies? And it may be more than one person, depending on the exception. So what is the policy and process and procedure around that to ensure that if you're going to assert an exception, that it's been properly analyzed and documented? And then what documentation are you going to require for saying that exception applies? Is there a way to develop forms? Is there a way to, develop a checklist? Anything that can make it easier, but ensuring that you meet the exception. Again, I encourage you to really review the exceptions carefully because they're very nuanced, and thinking through whether it applies or not is going to be critical. There are some limitations in instances where there are time frames for the exception, so you have to be cognizant of that. Now, I will tell you there is virtually nothing in the information blocking rule that, unless it's tied to the exception I just mentioned, that says how fast you have to do something. So the information blocking rule does not change the provisions of Hipaa that say when a patient requests access to their information, you have up to 30 days to reply. However, if you participate in the MIPS or promoting interoperability programs, you may have criteria there that is applicable. So think through not only what Hipaa says, but what other obligations you may have to provide the information in a more timely fashion. So just be aware of that and cognizant of that. But the information blocking rule doesn't specify a time frame for access, use, or exchange, with the exception of one of the exceptions. And how are you going to handle requests for access, exchange, or use on behalf of other parties? Because again, that you may have current practices in place that if you aren't already assessing, you need to assess to determine whether those need to be changed or whether you're still good to proceed in the way you have been in the past. Reviewing contracts. You might want to review contracts with your EHR vendors to determine if there are any terms in there that might constitute information blocking. You want to review existing contracts maybe with your business associates to determine if anything exists that could constitute information blocking, and be cognizant of that, and maybe reaching out and saying, we're not going to view this as an enforceable term of the agreement. And then, of course, when it's up for renewal, you want to modify that language so that there's not a risk of information blocking. You need to evaluate your systems. Does it have the capability to share the USCDI data elements? The one data element that I've talked to a lot of organizations about and they're having some issues with is how you share the provenance data, who authored it, the record, and when they authored it. And so you might want to look at that. If for the people who are saying we can share all of this through our patient portal, I've encountered a number of organizations who said that's the one piece that they can't share through the patient portal. Now, ONC has made it clear you are not required to share, to proactively share everything in the patient portal, but you do have to share information in the content and manner requested unless that's something that's problematic for you, and then you have to analyze that under the content and manner exception. So again, thinking through, I had one individual who said, had drafted an FAQ for the organization that said, the information blocking rule requires us to release lab results immediately to the patient. It's like, no, it doesn't specify a time frame. It specifies criteria and what could constitute information blocking, but it doesn't say that you have to do anything in any specific time frame other than, again, the one exception I mentioned. And again, if the system doesn't have that capability, then you might analyze it. And the two likely exceptions that could fit into that you could use to not share the data would be the infeasibility exception, and it should be the content and manner exception. Training and education. Again, thinking through Educating your workforce. You might need to educate a lot of your workforce on just what the rule is, and making sure, for example, those front desk folks don't just deny a patient request and say, well, we don't do that, rather than directing them to the right person to help them get the data, or evaluate whether there's an exception that applies for allowing them to have access to the data. And thinking through, what are people going to be doing that's new or different from what they've been used to doing over the years. Updating any policies and procedures, like that patient access policy and procedure may be something that you need to update. And what are they going to do that's new or different when third parties make requests for information? Again, if that competitor makes that request, it's not going to be okay to just deny it after information blocking. Somebody's going to have to analyze whether there's a basis for denying it. And then I think one of the key factors here also is refreshing everyone on what the designated record set is. I was working with one client and reviewing their designated record set policy, and their policy was written in such a way that they assumed the designated record set was a subset of the medical record, when in fact the medical record is a subset of the designated record set. And so those kinds of misunderstandings can be problematic. And keeping in mind, so the designated record set is the medical record, the financial information about the individual, and any other record used to make a decision about the individual. So that may be a factor that you have to consider. Was this used to make a decision about the individual? So for example, images. Most healthcare organizations I've worked in and worked with do not consider images part of the medical record. But the images were likely used to make a decision about the patient, so they are going to be part of the designated record set. And so that's going to be key to knowing where all of your data is, so that you can determine, is this part of the medical record? Is this part of the financial record? Is this part of the or was it used to make a decision about the patient? And again, just like the exceptions under Hipaa for what's not part of the designated record set would be applicable here as well. But again, thinking through, where's the data, what's it used for, and whether you can make it available. And something to consider, let's say you have a billing contract with a third party, so that third party does your coding and billing for you. Are they accessing your system, and so all the data and information's in your system, they're just manipulating it to get it ready to bill? Or are they maintaining that data in their system? And could some of that data be part of the financial record that you're going to have to figure out a way to make available to patients through that business associate? So again, lots of things to think about here. Now, there's just a couple of activities, obviously, you can hold off, and I think this is determining where all of your EPHI resides, and I'm talking about that stuff that's outside the USCDI for purposes of being prepared to be able to share it or allow access, use, or exchange after October 6th of next year. And figuring out what part of that is the designated record set and what isn't. Updating any contracts that may need to eliminate terms that could trigger information blocking. And then, of course, thinking about auditing and monitoring. Now, this may be something that you think about doing maybe a year from now, just to have an assessment of, are the new policies and procedures being followed? Are we having any questions or concerns or issues with practices that we think could be information blocking, etc.? I just listed here a few of the ONC resources. They've got an FAQ page that I think is very informative and has answered some of the questions that I've heard clients ask. They also have several past webinars. They just did a webinar this past Thursday on some of the FAQs they have out there, and that recording is going to be up on their website, as well as the slide deck. So I encourage you, I put the past webinars page there. I don't know if the webinar that was done on Thursday is up there yet, but they have several prior ones that I think are pretty good. And then they also have the exceptions page that I mentioned earlier. that you can click on the PDF on that page and get the list, the ONC's list of exceptions. So with that, as I mentioned, I'm going to share this deck with the group, and we can start our Q&A.
Excellent. So Marti, we've received some questions during the course of your presentation, and I'll just go through some of them now. One of the questions had to do with enforcement dates, and will enforcement dates differ between healthcare providers and other actors covered by the regulation?
No, the enforcement date is the enforcement date. It doesn't vary by actor type.
And then will hospitals be required to give EMR access to health plans?
I think you're going to need to look at the content and manner exception. So there's no, I think that's a maybe, but it really is going to tie back to the health plan may request it that you give them access, but if it's not feasible for you to do so, or if you can't share access in the way that gives them the content they're looking for without giving them access to other content, in other words, you can't separate the content out to just give them what they need, then you may get an exception. But I don't think that's a pure yes or no answer. I think it has to be evaluated to determine, are you legally prohibited from doing so? Is there another exception that applies?
Okay. And then here's a question that may be for the audience, but I'll pose it to you, Marti, which is how many organizations are ready for compliance on April 5th? And another related question that really expands upon that too, which is, where everyone is in the process. Are you at the beginning, the middle? Where are you with policies, processes, et cetera?
Well, I'll comment on that, and then if others want to chime in, please do. But as I said, I'm working with a client now that I think has a pretty good process in place. They have a project for this that they initiated, I think it was about 6 or 8 months ago now. And they've got a governance committee. They've got a whole process and structure around it. Now, I will say they're working with an outside law firm that helped them build that. But they've really structured it in a very thorough way, in my opinion, to really analyze any practice they have, determine whether it's a potential information blocking practice, and if it is, then they've sent it back to the business owners to make appropriate adjustments to the practice or process, so that they can be ready for the April 5th date. They've got an education committee set up to produce the education materials. They've got specific committees set up for things specific like clinical notes. They've got a number of questions around that. The release of lab results, they've got a subcommittee set up. So it's very, very structured. And then I've done a presentation or had a conversation with an entity earlier this week that, from everything we could tell, they'd done virtually nothing to prepare for this. And that's the second organization within the past 2 weeks that I've had that kind of conversation with, that they've done hardly anything. One of the organizations we talked with, the individual was very clearly aware of it, but they have been inundated with COVID. They've been operating at, I think, 160% of capacity for several months now. And so it's not been on the top of their radar. So I don't know what that is going to mean for them, and how ONC would look at that. I would hope they have some sympathy and empathy with that organization, because they've been buried with COVID. But who knows? I don't know whether, I haven't heard anything on moving the enforcement date from, or compliance date from that April 5th date, but who knows whether that theoretically could happen. I wouldn't rely on that though. Anybody else want to chime in on where they are in the process, or you think your organization has a good structure in place? Has this scared the bejeebers out of you? David, you want to comment on your, oh, you put it in the chat. You want to make a comment?
Yes, thank you. 2 points. First, as far as the potential for a delay, it is being discussed as a part of the overall milieu of COVID-19 public health issues and prioritizing the use of information technology for a number of purposes. But also there was an indicator of where the administration's thinking may be going in the recent COVID-19 executive order signed by President Biden within the last week or so, in which there are a couple of different sections talking about using the interoperability of health information to better share and coordinate public health data regarding COVID-19 transmission and the vaccination process. So I think there's a lot of balls in the air, and I think that everyone should continue on, as you suggested. I think everyone should continue on this track of April 5th is going to be a date, but also that there may be, that the administration may be looking to leverage different kinds of data, especially from hospitals, for public health purposes.
Thank you. Any other, I see one comment, we're about 6 months behind and yes, scared. So that doesn't surprise me. You know, I think in talking with some people, they kind of thought it was a little more basic than what it really is. And you know, as I said, I still find some organizations that think this is just about how you share data with the patient. And it's much, much broader than that. And I'm not aware, we haven't at CynergisTek created a checklist per se. And I don't know if others are aware of specific checklist or if they've got something that they've created that they'd be willing to share. And so if anybody does, please chime in and let your colleagues here know that. I would encourage you, again, to go out to the ONC website on their FAQs, because one of the questions that has come up is what a progress note is. And I think, again, some organizations may view that, well, that's the physician's note about what's going on with the patient. And ONC has been very clear that it definitely could be other types of healthcare clinicians. But if you click on if you go out to the USCDI webpage and you click on progress note, it has a brief descriptor of what a progress note is. And so that may be part of your analysis, because the other thing, you know, in working in Epic in my past life, we had a note type called progress note. And so, you know, that you may need to look at that and say, well, who documents a progress note? Because you may be including information that you don't have to, because not everybody who documents in that note type is actually documenting a progress note. And then the flip side of that is you may need to go look at other note types that, while they're not called a progress note in your EHR, would in fact fit into what a progress note is under USCDI. So it's not just saying, okay, everything that we list as a note type progress note is what we're going to share. There could be other note types that aren't one of the 8 note types listed in USCDI that actually meet the criteria of a progress note. So just being cognizant and aware of that also.
Marty, there are a few questions on or around policies and procedures. Perhaps we could speak a little bit to that. Some folks are indicating, you know, they're interested in if anyone has some new revised both, and maybe what some best practices are that you're seeing in the industry. Some folks are maybe wanting to know where to get started on the policy and procedure approach.
Yeah, I think it's a difficult question for me to answer, because everybody does things in a different way. I've seen organizations that have a HIPAA policy, and it's a 50, 80 page policy that pretty much encompasses everything they do under the rule. I've seen other organizations that break it out, and so they may have, I think when I was at UCLA, I had roughly 70 policies for privacy and information security, because we broke it out in a much more nuanced fashion and had shorter policies and procedures. It's a matter of preference for the organization. I have a strong belief in shorter policies because I look at the end user and I want to make stuff really easy for them to find. And if it's not easy for them to find in a 70-page policy, then that's you're eliminating the purpose of the policy in my opinion. But it really is, what do you have? And then also, you may have state law criteria that are going to come into play here. You may have criteria with other federal laws, depending on what kind of organization you are. If you do SAMHSA work under Part 2, that may come into play. So it's kind of difficult to have like a templated policy. I think it's really thinking through and looking at your current policies and saying, is there anything in here that we think could constitute information blocking based on what our current practice is? And then walk through how you would modify that, and then determine, like for the exceptions, I would be astonished if anybody had any sort of policy that had something like the exceptions in it that they could modify. So I think handling the exceptions are probably going to require a new policy, and it could be new policies. You could have different policies for each exception. It's really dependent on how your organization prefers to do it. But I would think that could definitely be a new one.
And then we do have a comment from one of the attendees related to perhaps their best practice on note types and what's being used from a mapping perspective. They are an Epic shop. That's the last post. I don't know if you want to comment on that, Marty.
Well, it looks like the comment was around, and I agree with this if I'm understanding it correctly, you pulled all your note types in Epic and then did a mapping for each note type on whether it would fit into one of the 8 note types under Uscdi. And I think that's really the process that needs to be utilized. Don't just say, well, we're mapping, the progress note type to share, because you could have other note types like PTs, RTs, OTs could potentially be documenting a note that would fit into the Uscdi criteria for a progress note type. So I see we have another question, Michelle, that someone's asking, is anybody using Cerner? And I think, I can't tell if you mean Cerner says they won't be ready for April, or you're asking if the other parties using Cerner are saying they won't be ready by April.
Oh,
Cerner says they won't be ready by April. I'm shocked by that an EHR vendor isn't got all this dialed in. For those of you on the call who know me, I'm being facetious. But it's a challenge when your technology solutions aren't there to help support you in this process. Another question that I've seen come up is, do we have to share everything in a patient portal? And ONC's been clear on that. The answer is no. You don't have to, there's no mandate to proactively share anything. The one thing to be cognizant of is if the patient requests the information through the portal, then you're going to have to be able to fit an exception. Either by law, we're not required to share the particular information, or fit into an exception for why you're not sharing it through the portal. And there may be a number of reasons. There could be technology reasons that you can't get that particular item into the portal. Some organizations have different EHRs for different activities, like radiation oncology. It's not uncommon that could be done in a separate EHR from something like a Cerner or an Epic. And if it interfaces into that EHR and you can pass it on to something like a MyChart in Epic, then you're okay. But if you can't, if there's not an interface and everything lives in that EHR for radiation oncology, then you're going to have to think through, how are we going to allow access or exchange, use or exchange of that information?
Marty, I wanted to circle back to the discussion on policies and procedures and just kind of throw one out here for you, which is, when people are thinking about policies and procedures, do they need to do all new policies and procedures? Do they need to dovetail into existing? What are some industry best practices that you're seeing?
I don't know that I can say there are industry best practices because this is so new. But again, I would go back to say, look at what your current policies and procedures say, and it may just be a tweaking of some of those. I do think there are probably at least one or two new policies you're going to have to draft. And as I already mentioned, one of those is around the exceptions. I think you're going to have, I think most organizations are not likely going to be able to incorporate into an existing policy, or it could be a new section, a completely new section to an existing policy. But I think it's going to be brand new text, whether it's in a new policy standalone or whether it's added text to a current policy. So if you think about how you allow patients to access their information, there may be one or two lines you tweak and update in a policy on that. Whereas, like I said, the exceptions may require a whole new section to a policy or a brand new policy.
Thank you. Next question. So, Marti, could you comment on or perhaps discuss the role state law plays in the consideration of whether the prohibited by law exception applies?
Well, yeah, I mean, if you think through in California, there is a prohibition against sharing information electronically prior to the provider being able to review the results for certain labs. It's a specified group of labs that fall under the regulation. But for those labs, you could delay release to, let's say, a patient portal based on that law, because the law says to do that. There's an interesting law in Oregon that says if you're a reference lab, then you may not release information for up to 7 days at the patient. If the patient requests it, you have to still wait 7 days unless the ordering provider actually authorizes the release of the information. Now, you have to parse through in that particular case, are you a reference lab, and in what circumstances might you be a reference lab, and what circumstances might you be able to release it immediately? But for those instances where the organization meets that definition of reference lab, then they can wait 7 days to release it if they haven't gotten authorization from the provider to do so, from the ordering provider to do so. So yeah, what you need to look to is, does state law prohibit it? Or even, well, the required by law could also be HIPAA. If there are certain prohibitions in HIPAA for sharing, or you have to meet certain criteria in HIPAA for sharing the information, then if it doesn't meet those criteria, then you could say we're prohibited by law from sharing it. But being cautious and clear, the privacy exception would be one that you could use if it requires authorization under HIPAA, but you don't have a valid authorization for the access, use, or exchange. But in that circumstance, you do have some requirements to support the person in getting a valid document. So, thinking through what's actually prohibited by law versus what might be prohibited in this particular situation, like the valid authorization. So you generally use the privacy exception for when they haven't provided a valid authorization and the access, use, or exchange requires that. Is that what you're going to comment on, David, or do you want to add anything else to that?
So thank you, and I was going to actually touch on two things, and the first is there was a comment, how do I classify this? Is this a privacy policy or a security policy? And one of the complexities of the information blocking regulation is that it melds together many of the concepts in your privacy and security, as you well know, Marti. So, but what some of I work with smaller clients. One of my clients are struggling with that old bugaboo of who is authorized to access, for example, a minor's healthcare records. Who is the personal representative? And then once you figure that part out, how do you set up your authorization to access those records so that only the right people have access to the right records? And it's a very complex issue that you have to kind of work together between your privacy team and your security team to make sure it gets implemented correctly. And in the case of smaller providers who really are struggling with resources, that it's an issue to be considered. And I'll stop there. Thank you.
No, and I do think that's a really good point that you're making, David, in thinking through how you parse that out. And I agree, it's a melding of the two. We did a short survey to ask who's involved in your team across some of our clients, and it varies a lot. The one client I mentioned that I'm working with, as I said, they have a governance group, and it's compliance, it's legal, it's security, it's physician leaders, other operational leaders, it's their EHR folks in IT. So it involves all of those folks. And, we actually, on our website, I published an ebook on this. And one of the comments I made, I think you're going to have to get a committee together. Now, in smaller organizations, maybe not quite so much, but in larger organizations, I think it's going to take a committee because there are a lot of stakeholders that could be involved here. And you want to make sure you've considered this. And it's like with anything. I mean, I think back when we implemented our EHR at one of my former employers, and everybody has a slightly different lens in which they're looking at this. And so, again, thinking about an entity I'm working with, one group says, release everything immediately. Just release it. Just put it out there. Release it immediately. And well, as you might imagine, some of the providers are saying, whoa, we're not comfortable with that. We want to maybe think about it. And, they would like to have a delay, quite honestly, on releasing some of the types of notes, like a pathology report, a radiology report. And as I read the ONC FAQ, that doesn't fit, that would be potentially be information blocking, because there's no legal basis for the delay, and they can't fit it into the risk of harm exception. And there are a number of ONC Q&As around risk of harm exception. And again, I'd encourage you to read those, because I think there are some providers who would prefer to use that, for lack of a better way to say it, a little loosely. And, if you look at what the criteria is, it's substantial risk of harm in a couple of cases, and it's actual endangering the individual's life or risk of physical harm in others. And so you have to say that. And so the scenario where, let's say you have a neurosurgeon ordering or a neurologist ordering an MRI, and the MRI gets interpreted by the radiologist. So you've got the radiology report out there. The radiology report says this looks like a probable glioblastoma. Well, if any of you know what a glioblastoma is, it's a pretty significant brain tumor. Well, if that goes to the patient before the neurologist sees that, then of course their concern is the patient's going to get very panicked, start calling the office, get really upset. So they'd like to have the opportunity to have reviewed it before the patient sees it, so they're prepared to have that conversation. I think that's a justifiable thought process, but ONC has said under information blocking, no, that's not a basis for delaying it. And I was on a call with some folks last week, and there was a comment by a physician who said, and I don't remember if he said the disease process, but apparently there's at least one, there might be more disease processes that when patients get diagnosed with it, there is a very high risk of suicide. A high percentage of individuals who get diagnosed with it commit suicide. But as I read ONC's comment, I'm not sure that would justify risk of harm exception without knowing that I'm in the high group that's likely to commit suicide versus the group that maybe isn't, without some other substantiating facts that says Marty's one of those people that we think is likely to commit suicide. I don't know that you're going to be able to fit the risk of harm exception. So I think that's going to be a little bit challenging for folks.
Marti, I do have a couple questions that I need to also include. One of the questions posed is, do the regs apply only to providers who use electronic records? This is coming from a clinic that just keeps paper records, and are they obligated under this rule?
So bear with me just a second here. I have to look and see if I brought this up. So I've been working on this Can you see the Word document?
Yes.
Michelle? Okay. And I have to get back to this so I can see it on my screen. I've got too much stuff open this morning. So this question was actually something that got brought up to ONC, and I've been putting this together, so bear with me. It's still a draft document. But are healthcare providers subject to the information blocking regulations even if they do not use certified health IT? Yes. So you can see this direct thing on the ONC's website. But if you meet the definition of an actor, you're subject to the rule.
Thank you, Marty.
And again, that's why I would encourage you, as I said, that one of the websites I listed on the last slide, resource slide, gets you to the FAQs. This is a document, as I said, I'm creating, but you can go out on their website and get to the FAQs to look at this. And they've got a number out there. This is a personal opinion, but if they put it out there and they put it under certain categories, but you have to kind of look for what's new. They did, the most recent one I saw, put the date that it was added, so you can kind of see what the new ones are, but you have to look for that and see what's new out there. So it's something that you want to check with some frequency. Does anybody, I hesitate to even ask this, but is there anybody on the call that wants to comment? Do you think you've got a good process in place that you can share with others on the call? Or is there anything that you've identified in going through your process that you're thinking, in starting out with this, I would have never thought about that or would have never considered that, or, the progress note question was one that came up for me that I hadn't really thought through until I dug into it a little deeper and realized that a progress note really isn't the note by just the physician, but note by others, and could be nursing, could be PT, could be other types of clinicians that what they document could be considered a progress note in USCDI. Anybody want to share? Other questions, comments? I mean, I know we scheduled 2 hours for this, but if folks don't have anything else they want to ask or talk about or think about,
So
Michelle?
Marty, I may have already asked this question, but I'm going to plead I haven't had enough coffee if I have already asked it. The question is, will hospitals be required to give EMR access to health plans? Did I already ask that question?
You did.
Yeah, I guess I'm a little blown away by the example of the test result where the patient may have a risk of suicide if there's a known percentage. I would hope there's going to be a reasonableness standard, and that disclose. I know we don't want to have I guess we're trying to get away from having such a paternalistic medical community, and that the doctor can't share results, or the doctor has to review results before they're shared with the patient. But that seems very compelling to me of a reason not to. So I'm curious. I guess it'll, down the road we'll find out if they start leveling, civil monetary penalties for sharing information. If a physician truly thought it could cause harm to the patient or they wouldn't understand it. HIV, pancreatic CA, brain tumors, things like that. For their patient to see that before the doctor can discuss with them, I really have a problem with that. I guess I'm just a little shocked that could be a scenario going forward.
Yeah, and I think there are a lot of providers are, because I think their view of it, which I think is legitimate, is if I have a chance to look at that result, I can then be prepared to have the conversation for the patient, as opposed to having the patient go into a tailspin. And perhaps, right. I'm sure, I think we have a few providers on the call. You've had those experiences where, you have the patient that goes into the tailspin and it's really not that big a deal. They give the high-low values for a lab result, and I'm 3 points over. Maybe the value range is, it could be 200 to 500, and I'm 550, and I'm like, oh my God, what's going on? What's wrong with me? What's happening? And they go into a tailspin over that. But I think your example is more that glioblastoma case where
Right.
that's what's written on the radiology report. And if I see that, I think several of the clients I'm working with are talking this through and saying, it's probably going to be a bit of a shift in how we practice medicine. And they're saying, it's going to be talking with that patient before the MRI occurs and saying, look, we're doing this assessment, here are possible outcomes. Don't panic when you see the outcome. We'll schedule an appointment for me to talk through with you what it means, to kind of, prepare them for the idea and prepare them that you may see these results before I've had a chance to fully ingest them. And so, don't panic. We'll talk about it. We'll talk through what's going on, what that means for you. And just kind of doing that expectation setting with the patient before the service is rendered. And again, it's for me personally, it's a little bit of a double-edged sword in thinking about it, because as a patient, I would want to see it. I would want to start preparing. I'd want to start doing research on it. So I'm prepared to have the conversation with the clinician when it happens. But I also suspect for many of us on the call, I would say we're probably more sophisticated healthcare consumers than the average.
I agree.
And so, that's the other thing to keep in mind. So as a patient, I might feel slightly differently about it than I do as a consultant that's supporting healthcare entities with this.
The other question I had is, does the patient or the third party have to give a reason of why they're requesting the records?
The patient does not. The third party may. It's going to depend, but the third party may not have a right to the record unless they can fit certain criteria. So they may have to specify that.
Would you think a workers' comp or an employer would be able to have access to results without the patient knowing?
Again, I think it's going to potentially be circumstance specific, but let's say you're requiring me to get a drug test for pre-hire screening. You're not going to need my authorization to get the results of that blood test.
Okay.
But if it's a surveillance type of activity where, let's say if I am positive, like positive for TB, the employer's going to need to know that and they're probably going to go through I'm not an employee health clinic that is not going to be covered by Hipaa. And so the results aren't falling under the Hipaa regulations if you're going through an employee health clinic to get the service done. But let's say I come in and get COVID tested as a patient, not as an employee, then I don't believe, and I haven't dug into this deeply, I don't believe the employer would then, be entitled to that per se. So again, I think it's like many of these things, unfortunately, it's nuanced, and you're going to have to kind of, parse through what the specific situation and criteria is, look at what the legal obligations are, and then come to a conclusion.
Great, thank you.
And by the way, I forgot to mention this at the beginning. I want to be very clear. Although I'm an attorney by training, nothing I'm saying here is legal advice. If you want legal advice, go hire an attorney to get that legal advice.
Understood.
So Marti, I'm going to tuck in a question that ties into what you were just speaking to, which is how does the Hipaa accounting for disclosure standard apply in the case of third-party disclosure?
Well, it doesn't change. If you're required to account for the disclosure under Hipaa, you're required to account for the disclosure. Nothing with information blocking changes that. If it's for TPO, you're not required to. There are obviously certain other criteria. If it's in a limited data set, you're not required to. But any disclosure that's currently required to be accounted for under Hipaa is still going to be required to be accounted for.
And then I have a couple more questions that have been coming in, Marti. Circling back to lab results, requesting some clarification on lab result release. We currently don't have to proactively post to the patient portal, but we are required to provide immediately if the patient requests it. So the question is, that is the question. Do we have to proactively post to the patient portal, but are we required to provide immediately if the patient requests it? They're commenting that their clinicians are struggling with this particular question.
Well, I might be hearing two different questions there, so I'll try to answer it in that way, and if it doesn't get it, let me know.
Okay.
There's nothing in information blocking that requires you to proactively post something to a patient portal. But if a patient requests that that's the manner in which you share the information with them, then you are going to have to share it with them in that manner unless an exception applies. So, for example, I mentioned a client I'm working with that has an application in which they store scanned documents. And I don't remember the specifics, but my hypothetical is going to be, if they don't have a technical way to share those scanned documents in the patient portal, and the patient requests information that's in those scanned documents, then they might be able to use the content and manner. They'll use potentially the infeasibility exception for sharing it through the portal, but then they can provide an alternative manner in which they would share it, say a printed copy of that information. So again, it's kind of parsing through what's the reason. You don't have to proactively share it in the portal, but if the patient requested in a certain manner, then you're going to have to provide it in that manner unless there's a basis by which you can't, and then you have to go through determine which exception is applicable for that. And then the other question is, I thought part of that question was around, again, the issue we were talking about a moment ago about providing results prior to the clinician being able to evaluate them. And again, as I read the ONC's FAQs, the provider's preference to see the results before the patient is not a basis to delay sharing the results. I saw another one. How does, oh no, that's the same one. I thought I saw a different question. Oh, our workforce member, if a workforce member requests access to their own medical record, would the organization be required to allow it? I don't see that as information blocking so much, because I've always taken the position that when you're a workforce member, your access to the record is as a workforce member to do your job. If you're a patient and you want access to your patient record, then you would have access just like any other patient has access. Now, I know some organizations do permit individuals to look at their own record if they've got access to the EHR to do their job. That's an organizational preference to do that, but there's nothing in information blocking that says if you currently say, if your access to the EHR is as an employee and you can't access your own record that way, there's nothing in information blocking that says now you have to allow that individual to be able to directly access their record through the EHR because they've got access as an employee.
And Marty, we had a question about images. Question is, are images required to be shared?
They will be. Again, what you have to look at for April 5th is what are the data elements under USCDI? And so you have to be prepared to share those data elements under by April 5th. And then by October 6th of next year, you have to be prepared to share anything that's part of the designated record set. And so remember, designated record set includes anything that was used to make a decision about the patient. And so, excuse me, images were used to make a decision about the patient. And so you'd have to be prepared to share those by October 6th of next year. And I'm just going to put this up here for a second. So these are the USCDI data elements. And so if you go in here and you click on these, like for progress notes, note made by a nurse, physician, social worker, physical therapist, or other healthcare professional that describes patient condition, treatment given, or planned. So as you think about that, obviously that could be a number of different types of notes. And that's what I meant when I said you may not call the note a progress note, but it may fall into the USCDI criteria for a progress note. And then the other thing to look at, if you look at provenance, you have to have the author timestamp and the author organization. And are those data elements you have in your record author timestamp? Probably, but is that readily available to be able to share with the patient or another party requesting the information? So that's the one that I've heard a lot of organizations are struggling with under this. And so you think this is, this is what you have to be prepared to share by April 5th of this year. And then, of course, virtually anything in the designated record set. Now, if the patient doesn't have a right to access it under USCDI, then you may not necessarily you won't probably be required to share it. But that's where I was saying you need to know where all your data lives, because a lot of folks look at this and think the patient only has the right to access the electronic health record or the electronic medical record. And they don't. Even today under Hipaa, the patient has the right to access the designated record set. And for a lot of organizations over the years, I've said, define what constitutes your medical record. And if the patient asks for a copy of their medical record, then you can say, this is what constitutes our medical record, this is what we're sharing. And it wouldn't likely be the same as the designated record set. However, I don't think anybody's going to be surprised to hear me say, I have in the past explicitly requested my designated record set from providers, and I have never gotten it on the first pass, because invariably what I have gotten is a copy of my medical record. And so that's why I mentioned in the education, re-educating everyone so they're clear on what the designated record set is. And again, that's not critical for April 5th because it's only these USCDI data elements that have to be shared, but it is important that people understand, even today, the patient has the right to their designated record set, but going forward for information blocking purposes, it's the designated record set. And I think, again, that's going to be important to always keep in mind, but it's also going to be important as you assess data and where the data is and what its purpose is. If the data that you're holding is, say, a database for quality purposes, that's not part of the designated record set. It's protected health information, but not part of the designated record set. So, but it's really doing that data inventory and understanding what the nature of the data is so that you can determine, yes, it's part of the designated record set, or no, it's not.
And Marty, we have another question in the chat. It has to do with the patient portal. Are organizations required to have all of these elements available by April the 5th for patients through the portal?
You're required to be able to, or to identify why you can't. So you don't have to proactively put them out there. But again, the rule says if I request the information in a certain manner, you're required to give it to me in that manner unless there's a reason you can't. So again, if it's infeasible for you to give me the information through the patient portal, if I say, I'd like for you to share this with me in the portal, and you say, technically, we can't do that. We can't share that particular item with you through the portal. You can propose an alternative manner to sharing it with them and come to consensus with them in that alternative manner. But one of the things to also keep in mind, and this is why I reiterate, the exceptions are nuanced. When you look at that, there's a sequential assessment of the manner in which you can share it. If you can share it through, and I'm going to blank on this, I've got a document that I reference, on calls I'm on with clients. This document, when we're talking about information blocking, is almost always on my screen so that I can go back and forth to it and walk back through it and look at the nuance of this, because again, that's the thing that I think is going to be important here, is thinking about the nuance. So this is a copy of the CFR for information blocking. And when you go to the content and manner exception, if you want to share it in an alternative manner, then you have to fulfill it by evaluating this sequentially. First, you have to assess, can you fill it using a technology certified to standards adopted in Part 170? If the answer is no, then you have to evaluate it. Can you share it in a content and transport standards specified by the requester that have been published by the federal government or by a standards organization? If the answer is no, then you would go using an alternative machine readable format. But you can't just jump to the machine readable format. You have to be able to say, I can't do it under A, I can't do it under B, to then say C would be the way you would do it. So, again, the nuances of this are really going to be important, and that's where part of this is going to be training and education of folks to make sure they can't just say, okay, I'll give it to you on a CD. Maybe the CD is the way you're going to have to give it to them, but have you assessed whether you can do it through a different type of technology, through a content and transport standards that are specified by the requester and published in these ways? And then you would get to the machine readable format. So again, this is a lot of information, I know, to know and cover, and that's why I'm saying have that policy for who are the parties that can assess whether the exception applies, and who can authorize to say yes, an exception applies, and that's why we're not going to share it, or we're not going to share it in this way. Any other questions, thoughts, comments? I would love for you folks, if that have accessibility. Well, we didn't reiterate. Some people at the beginning of the call said they didn't have access to the chat. And if you do still haven't been able to get access to the chat and you do have a question, we offered up texting Michelle. I don't know if you've gotten any text, Michelle.
I have, but I'll give my number again. It's 512-633-0643 if you would prefer to text me. I do have another question, Marty. Let's see, it has to do with the patient portal. If the patient signed up for the portal, why wouldn't they want to have these data elements out there? Perhaps they're overthinking it, is the comment from the chatter.
So I'm sorry, I'm not clear on the question, because if the patient signed up for the portal, that is a way that you can share the information with them, but the patient may request the information in a different format. And so again, you have to think through, and remember, the patient isn't the only party that can request this. And that's probably the more instance where the content and manner exception may come into play. But think about the patient who says, I want to get the data through this app that I'm using. Then that's the manner in which they've requested it. And if you have some reason that you can't share it via the app, and you say we can't share it that way, but we can give it to you in the portal, that may be the alternative method, and that's using a certified health IT through your portal generally. So again, you're going to have to think through. Don't assume that the patient's always going to want it in their portal. And so that may be the issue. They may want it through, they may look at the portal, but they may also want it through a different format. And then again, it's not just the patient that can request the information. So when you think about a third party, non-patient asking for the information, you may not be able to give it to them in the manner they're requesting, and that's when you're going to have to do that content and manner analysis.
Another question on the portal, Marty. Can patients still opt out of having their information on the portal?
I'm not sure I'm completely understanding the question, because obviously a patient can opt not to participate in your portal. I'm not aware of any organization that mandates that people participate in the portal. But if your question is, can a patient opt out of having certain information in the portal? I think that's really, to me, what your technology would permit you to do. I think that went back to David Holtzman's comment a while ago about minors, because that's always been a challenge in patient portals with minors, where you have state law that gives the minor the right to control certain elements of their record over the parent, who would normally be their legal representative. So let's say for reproductive health issues. If you know, I have a daughter that's 16 years old and she goes to a provider to get birth control, and if that falls under state law that she can do that, and that becomes her record to which she has the authority to have oversight to be able to share and exchange, then if that data goes into the portal and I've been granted proxy access as the personal representative, then how are you going to ensure that I don't get access to that information about the reproductive health services? That's been the challenge a lot of organizations has tried to deal with, and I don't know what solutions people came up with. I know the last time I was in a healthcare provider, the solution we had, because there were some provisions in that particular state that gave the patient rights at the age of 12. So we started out saying we're going to deny the patient portal to anybody between the ages of 12 and 18, because we didn't have a good way to segregate out the information that the patient had the right to control from the information that the personal representative had the right to control.
Marty, I don't have any new questions from texting or the chat. If anyone wants to unmute themselves, they're more than welcome to ask a question. We didn't.
So Marty, I'm so sorry I had to step away for a moment, but I did hear the conversation about the sharing of the minor, and can someone opt out of having their information in the EHR? And I think that raises a really interesting issue for which I don't have any answers for, but I'm going to throw it out there, is if someone opts out of having their information in the portal, can that information nonetheless be shared with the third party through HIE or some other element? And I think that's really a interesting issue that may be something that we're going to have to face as an industry going forward. Just throw it out there.
Yeah, I agree, David, because a similar situation came up in a conversation I was having with a client that they were really focused on how they would share or not share information in the patient portal. And this was around their discussion of delaying release of pathology reports and imaging. And the comment was, well, we can delay releasing those to the portal, but if the patient comes to the HIM and asks for their records through the release of information process, they will get that record. There wasn't any process. If they were going to delay it, it was really only being delayed in the portal, and there was no process to delay it if the patient came in person and said, I want a copy of my record. So it was kind of interesting to kind of walk through and think through, how do you want to put a process in place? And I think with ONC's FAQ, it became clear that it's non-issue in the portal now, because ONC has essentially said if it doesn't meet the risk of harm or another exception, you need to share it. But I agree. There's a number of complexities that are coming up that are very nuanced and teasing through. One question I had was, if you've got a business associate relationship and the business associate is maintaining information that would fit into the designated record set, and you terminate the relationship with that business associate, but there's a conclusion that it's infeasible for them to return your data, so now they're holding a portion of the designated record set, what, if any, obligations are you to be able to be prepared to make that information available? I want an answer to that, because I don't have one.
I'd be more prepared to answer the question, will we fix the healthcare system in America or reach Mars first? I think that's an easier question.
Well, if it was all easy, none of us would have jobs. So I guess that's a silver lining. So I had a comment here in response to your question. The one that says, in our organization, the answer is yes. Patients can opt in or out of the portal of HIE sharing, the EMR vendor sharing, and third-party app sharing, and sharing between providers for TPO purposes. So to me, that sounds like part of it is tied to just an opt-in, opt-out, and part of it could arguably be tied to a request for restriction. And it's interesting how that gets operationalized, because I think that's what I've heard a lot of organizations talk about. The challenge is, how do you operationalize it? You know, you might be willing to do it, but it's not easy to operationalize. And I don't know if you're in a large organization or a small. Oh, the response was yes, it's very cumbersome. So that doesn't surprise me. And that may be something that you need to look at what you're doing today, just to ensure that the practices here couldn't constitute information blocking, and that you've got all the right documentation. Even though you're allowing it, do you have all the right documentation to help defend against an allegation of information blocking? And you may very well, I'm not saying you don't, I'm just saying these are some of the analysis that I think you're going to want to look at and go through. All right, well, thank you, everyone.